Pulse assessment is a basic but highly important nursing skill because it gives us immediate information about cardiovascular function. When we assess a pulse, we are not just counting beats per minute, we are also considering rhythm, strength, and whether circulation appears adequate. In practice, the two most common methods discussed here are radial and apical pulse assessment. The radial pulse is taken at the wrist and is often used for routine checks because it is quick, convenient, and non-invasive. It works well for many stable adult patients with a regular rhythm. The apical pulse, by contrast, is taken directly over the heart with a stethoscope. Because it reflects central cardiac activity, it is more accurate when the rhythm is irregular or when the patient has a cardiac condition. Think of radial pulse as listening to an echo at the edge of the body, while apical pulse is listening at the source. As nurses, our responsibility is to choose the best site for the situation. If findings seem abnormal, irregular, or clinically significant, we should verify them with an apical assessment to support safe decisions and accurate documentation. Pulse assessment matters because it gives clinicians a fast picture of how effectively the cardiovascular system is functioning. A pulse tells us the heart rate, but it also tells us whether the rhythm is steady or irregular. That information influences everything from routine monitoring to emergency interventions. For most adults, the normal resting pulse range is 60 to 100 beats per minute. Values below 60 are called bradycardia, and values above 100 are tachycardia. However, numbers must always be interpreted in context. A trained athlete may normally have a pulse under 60, while a patient with fever or pain may temporarily have a pulse above 100. The key question is whether the rate fits the patient's condition. For example, a postoperative patient with tachycardia may be in pain, bleeding, or dehydrated. A patient taking a beta blocker may have bradycardia related to medication effect. Nurses use pulse findings to decide whether to continue observation, reassess, hold a medication, or notify the provider. In short, pulse assessment is not just a task. It is a clinical decision-making tool that helps us recognize change early and protect patient safety. To locate the radial pulse, move to the patient's wrist on the thumb side. Anatomically, the radial artery is found lateral to the flexor carpi radialis tendon. In simpler terms, you are feeling along the thumb side wrist where the artery runs close to the surface. Use the pads of your index and middle fingers, not your thumb. This is a classic rule because your thumb has its own pulse, and that can trick you into counting your own heartbeat instead of the patient's. Proper positioning also matters. Support the patient's forearm and encourage the wrist to relax. If the patient is tense or the wrist is flexed awkwardly, it may be harder to feel the artery clearly. Start with gentle pressure, then increase slightly if needed. Too little pressure, and you may miss the pulse. Too much pressure, and you can partially occlude the artery. Think of it like tuning a radio. Too little contact or too much force both reduce clarity. In nursing practice, taking a moment to position your fingers correctly improves accuracy and patient comfort. Good landmarking is the foundation for reliable pulse assessment and helps prevent unnecessary recounting. Once you have located the radial pulse, the next step is to assess it systematically. Begin by noticing not only the rate, but also the rhythm and the general quality of the pulsation. If the rhythm is regular, you may use the 30-second rule. Count the beats for 30 seconds and multiply by 2. This is efficient for stable patients with an even rhythm. However, if the pulse is irregular, you must count for a full 60 seconds. An irregular rhythm means the beats are unevenly spaced or vary in strength, and a shorter count may underestimate or overestimate the true rate. This is a major safety point. For example, if a patient's pulse seems to skip beats, a quick 30-second estimate could miss a clinically important dysrhythmia. In that situation, count for 1 minute and consider confirming with an apical pulse. As nurses, we must avoid rushing through timing rules because accuracy influences treatment decisions. Document the rate, whether the rhythm was regular or irregular, the site assessed, and any concerns such as weakness or inconsistency. Good technique turns a simple wrist count into meaningful clinical data that supports safe care. The apical pulse is assessed over the apex of the heart, which is located at the left fifth intercostal space along the midclavicular line. This landmark is essential because accuracy depends on proper placement of the stethoscope. To find it, first identify the spaces between the ribs, called intercostal spaces, and count down to the fifth one. Then imagine or locate a vertical line dropping from the midpoint of the patient's left clavicle. Where that line meets the fifth intercostal space is your target area. This is the point where the heart's apex comes closest to the chest wall and where heart sounds are heard most distinctly. If the patient is sitting upright or lying supine comfortably, the landmark is often easier to identify. Think of this as finding the strongest speaker in a room rather than listening through a wall. Unlike the radial pulse, which is felt at the periphery, the apical pulse is heard directly near the source of cardiac activity. For nurses, correct landmarking is especially important in infants, cardiac patients, and anyone with an irregular rhythm, because an inaccurate location can lead to an inaccurate heart rate. To assess the apical pulse, place the diaphragm of the stethoscope over the apical landmark and listen carefully to the heart sounds. You are counting the paired lub-dub sounds, with each full cardiac cycle counted as one beat. Unlike the radial pulse, the apical pulse should be counted for a full minute every time. This is because it is often used in situations where precision matters most. Apical assessment is especially useful when the radial pulse is irregular, because you are listening directly to the heart rather than depending on peripheral transmission of the pulse wave. It is also the preferred method for infants, whose small peripheral arteries can make radial palpation difficult. In cardiac patients, the apical pulse is often prioritized because it provides the most accurate rate before interventions such as medication administration. For example, before giving digoxin, the nurse should assess the apical pulse to check for bradycardia. If the rate is unexpectedly low or the rhythm seems abnormal, the medication may need to be held and the provider notified. In practice, the apical pulse is our high accuracy method, especially when patient safety depends on exact heart rate measurement. Radial and apical pulse assessments each have an important role, but they are not interchangeable in every situation. The radial pulse is a peripheral assessment taken at the wrist. It is quick, easy, and practical for routine vital signs in stable patients with a regular rhythm. The apical pulse is a central assessment taken directly over the heart, making it more accurate for determining the actual heart rate. A helpful way to remember this is that radial tells you what is reaching the periphery, while apical tells you what the heart itself is doing. That difference matters clinically. If a patient has an irregular rhythm, weak peripheral perfusion, is an infant, or has a known cardiac disorder, the apical pulse is preferred. Another essential rule is verification. If a radial pulse is abnormal or irregular, confirm it apically. For example, if you count a radial pulse that seems to skip beats, you should not simply document it and move on. Confirm centrally so that your next nursing action is based on accurate data. This comparison helps nurses choose the right method, avoid false reassurance, and ensure that concerning findings are followed up appropriately. Pulse assessment is closely tied to medication safety. Certain drugs directly affect heart rate and cardiac function, so nurses must assess the pulse before and after administration when indicated. Digoxin increases cardiac contractility, but one important side effect is bradycardia. Because of that, the apical pulse should be checked carefully before giving it. If the heart rate is too low or irregular, the nurse may need to hold the dose and notify the provider according to agency policy. Atropine has the opposite effect and increases heart rate, so monitor for tachycardia or rapid changes after administration. Beta blockers decrease heart rate and can also contribute to hypotension, so both radial and apical assessments may be relevant depending on the patient's condition. In general, pulse rates below 60 or above 100 beats per minute deserve careful interpretation in context. Another advanced concept is pulse deficit, the difference between the apical and radial rates. A deficit greater than 4 beats per minute is concerning because some heartbeats are not generating effective peripheral pulses. This can suggest impaired cardiac efficiency or dysrhythmia. Medication decisions and abnormal pulse findings are deeply connected, making precise assessment an essential nursing responsibility. Let's bring the key ideas together with a few memory aids and clinical rules. First, remember radial equals W wrist. That helps you quickly connect the radial pulse with its peripheral wrist location. Next, apex equals apical, reminding you that the apical pulse is taken over the apex of the heart at the left fifth intercostal space along the midclavicular line. For timing, use the 30-second rule only when the radial rhythm is regular, then multiply by 2. If the rhythm is irregular, count for a full 60 seconds. The same 60-second rule applies to all apical pulse assessments because accuracy is the priority. When listening apically, remember lub-dub. Each complete cycle counts as 1 beat. Finally, keep the major safety rule in mind. If the radial pulse is abnormal or irregular, confirm it apically. Also prioritize apical assessment for infants, cardiac patients, and patients receiving cardiac medications such as digoxin. If you remember the site, the timing rule, and when to choose the more accurate central method, you will make safer nursing decisions. These simple cues help turn memorization into clinical judgment at the bedside.